classify the malocclusion and the etiology of malocclusion, right? So there are two ways of recording the malocclusion. And what is malocclusion? Malocclusion is the deviation from the normal occlusion, right? Malocclusion is a deviation from normal occlusion. What was normal occlusion? It was a deviation from the ideal occlusion within the physiological limits, not showing any pathological conditions. But in case of malocclusion, it is a deviation from normal occlusion, which can show signs of some pathology, or it could be outer the normal range. How to record it? There are two ways. One is qualitative and the second is quantitative. Quantitative, when you talk about quantitative, it means with the numbers, right? So in qualitative, we have two classifications. The first one is Angles classifications, which I'm sure everybody is. This we finished already. Okay, so it means we are left with only left with this etiology of malocclusion, right? Okay. So what is etiology of malocclusion? It is specific causes of malocclusion. It might be genetic influences or it might be contemporary perspective, the new ways of thinking about the etiology of malocclusion. So it could be a disturbance in the embryological development, it could be a skeletal growth disturbance, it could be a muscle dysfunction, acromegaly in hemimandibular hypertrophy, disturbance of dental development, right? What about genetic influences, environmental influences, and equilibrium theory and development of the dental occlusion? Functional influences on dental development, right? There are changing views of etiological possibilities, that is the contemporary perspective, etiology of crowding and malocclusion, and malalignment, and etiology of skeletal problems. Coming to specific causes, there might be disturbances in embryological development, such as these range from genetic disturbances to specific environmental insults. I'm sure you have heard about teratogens. What are teratogens? They are chemicals and other agents that are capable of producing embryological defects if given at the critical time. Means when there is some stages of development going on, and these chemical agents or other agents are taken by the pregnant woman, can result in malocclusion, right? Less than 1% of children who need orthodontics had a disturbance in embryological development as a major contributing cause. Here are some examples of teratogens. There are so many chemical agents which can produce these defects in embryo, but we will discuss about the most common teratogens which we have heard and we use in our normal daily life. For example, amyotropine, aspirin, cigarette smoking, dilantin, anti-epileptic drug like rubella virus, cytomegalovirus like X-ray radiations, Valium, sedative, right? Vitamin D excess. These are the agents, commonly used agents, which can produce embryological defects, which are very common in our patients, like cleft palate, right? So if you see, there are some agents, common agents, which can cause cleft lip and palate if taken at the critical time, means during pregnancy and development of the jaws. For example, cigarette smoking, which causes hypoxia and might result in cleft lip and palate. Aspirin, which is a most common over-the-counter drug, which everybody can take it without prescription, and people use it very commonly. It can cause cleft lip and palate if taken at the wrong time, right? Six, mercaptopurine can also cause cleft lip and palate. The Valium, a very common sedative drug used for sleep or sleep disorders, can cause cleft lip and palate as well. Vitamin D excess could be a result of premature suture closure, results in microcephaly, means small heads, right? So there are some teratogens you should know about it and what they cause. Thalidomide was a drug, right? It was introduced from Germany in 1957 but was never approved by FDA, prescribed to pregnant movement to combat morning sickness, which is very common during pregnancy first trimester, and if taken can result in various defects like short limbs, hemifacial microsomia, but this drug was banned in 1960s. Hemifacial microsomia affects the development of the lower half of the face, right? Hemifacial means half of the face. Micro means small, somia means mouth. So small mouth, and this is occurring in lower half of the face, most commonly the ears, the mouth, and the mandible, right? In fourth week of intrauterine life, if the vascular problem leads to clotting and a poor supply of blood to the face, that is the suspected cause of this embryological defect. Exact definitive cause is unknown. You might encounter with another skeletal growth disturbance which results in severe birth if, and the most common cause is mechanical and not the chemical. Here teratogens are not involved. What is the cause of this problem in which the maxilla is deficient is the embryo, or the embryo presses the arm against the chest, right? So arm is pressed across the face in uterus, which might result in mechanical disturbance and result in maxillary deficiency. Or another thing in which the mandible is severely deficient, if you can see it in the right picture, it's a Pierre Robin anomaly or a sequence. Previously, it was considered as a syndrome, but now it is not considered as a syndrome. It is a consequence, actually. It's a sequence of some steps. If the patient's head is flexed against the chest, mandible does not have the space to grow. And why it happens, why the infant presses his chest against the head, that is that discrepancy is because of less amniotic fluid. The amniotic fluid is responsible for the proper positioning. If the amniotic fluid by any chance is less, it results in pressure against the chest. So chin does not have the space to grow and results in very small mandible, and as a consequence it results in cleft palate plus severe respiratory distress. That's why it is also known as Pierre Robin triad. There are three things which you can find at the birth. That is a small mandible. Sometimes it is very small, resulting in severe respiratory distress and needs urgent care at that time. Most of the times, or some of the time, you can say it needs an urgent surgical intervention that is tracheostomy, right? Some other examples of skeletal growth disturbances are fetal molding at birth injuries. During the intrauterine molding, pressure against the face could result in TMJ disturbances. Birth trauma to the mandible, which was done by forceps used in delivery. So it is also a mechanical cause, right? An arm is pressed across the face in uterus, resulting in severe maxillary deficiency at birth. This is the one thing you can find. The fetus head is flexed tightly against the chest in uterus, preventing the mandible from growing forward normally. Related to decreased volume of amniotic fluid, as I said, extremely small mandible at birth, usually accompanied by a cleft palate. Why it results in a cleft palate? Because the small mandible, there is no space for the tongue to come forward. It results in posture of the tongue in between the palatal shelves, which hinders or prevent the palate to become fused. The palatal shelves to become fused, resulting in cleft palate. So that's why we call it Pierre Robin triad or a sequence, that because of the small mandible, it results in protrusion of the tongue in between the palatal shelves, resulting in cleft palate, and as a result of that, the tongue goes back and might block the respiratory airway, which results in severe respiratory distress at birth. Now, the childhood fractures of the jaw could be a cause of malocclusion. How 75% of children with early fractures of the mandible condylar process have normal mandibular growth. Why? Because children have green stick bones, they have soft bones, flexible bones. Most of the fractures goes unnoticed and the patient recovers and the kids recovers. But in 25% of the cases, it might result in later discrepancies like deviation of the mandible, smaller jaws, and atrophy of the mandible or TMJ distances. See, if you can see here, the fracture of the right condylar process at age 2, which resulted in facial asymmetry because one side is growing properly and the affected side is not growing. So the growth is restricted on one side. Then these defects could be a result of muscular dysfunctions, right? Damage to the motor nerve results in development of that part of the face, means the nerve which is supplying to that part will be affected. Excessive muscle contraction of the neck on one side, that is torticollis, a twisting of the head caused by excessive tonic contraction of the neck muscles on one side, primarily the sternocleidomastoid, results in facial asymmetry. So the disease is facial asymmetry. And what could be a cause? The cause is muscular dysfunction. The muscular dysfunction comes from the damage to the motor nerves, which results in twisting of head caused by excessive tonic contraction of the neck muscles on one side, resulting in facial asymmetry, resulting from the damage to the motor nerve and the muscle atrophies when it is motor nerve and the supply is lost. This is also considered, but it is a genetic disorder, acromegaly and hemimandibular hypertrophy, right? As the name suggests, there is one-sided mandibular increased in length. The cause is basically the anterior pituitary tumor. Why, why the anterior pituitary tumor is causing this hypertrophy or overgrowth? Because it secretes the growth hormone. Due to the presence of tumor, it results in excessive secretion of the growth hormones, resulting in excessive growth of the mandible and long mandible. Even if the tumor is removed, the skeletal deformity persists because it is already grown. So it will not go back, and the jaw surgery is required. This is also one condition you can find very commonly. The patient comes to us due to the absence of teeth, right? Can anybody tell me what is the name given to the condition in which there are 2 to 6 teeth missing in the oral cavity, congenitally missing, or completely missing, or some number of teeth are missing? How do you differentiate between these conditions? What are the names given to these conditions? If you find a patient, young patient, who does not have any tooth in the oral cavity, what you call that condition? I want to make sure I'm not talking to the computer screen only. I'm talking to Badr, Mashari, Sultan, and Ali. Is it true? Hello? Can anybody hear me? Are you guys there? Yes, Ali. Can you please tell me the name of the condition in which there is no teeth in the oral cavity? Or anybody else? If you don't remember it, tell me so that I can continue with the slides. I will explain and go on. Does anybody remember what is the condition called if two or three teeth are missing from the oral cavity? What do you call it? No, I am saying if two or three teeth are missing from the oral cavity, not the long jaw. Badr, are you there? Sultan, Mishari, are you there, or you just open your mobiles and you left the place? If nobody is listening, then I can stop the lecture. You can open. I know, Ali, you are with me, but I think you are the only one. So we can have session sometime else. We can discuss things. There is no need to waste our time, right? This time was chosen by you guys, right? Dr. Shaheen told me that you people want lecture online from 11 to 12 at night. I was willing to come to the lecture hall in the morning as well. But Dr. Shaheen told me that you people are not still in Abha, so you want lecture at night. That's why I waited for so long. Anyways, the condition is called as anodontia. This is very insulting, by the way, Ali, that nobody is here in the class. Even I'm trying to speak to you people. Out of four, three are already sleeping, right? They opened the mobile and they are sleeping. They're not here. It's very disappointing for me. Sorry to say. So, anodontia is a condition in which the total absence of teeth. Hypodontia, we call it when some teeth are missing, right? Oligodontia, when 2 to 6 teeth are missing. But sometimes it is isolated, and sometimes it is considered as syndromic or related to other diseases. Like you will find thin and sparse hairs, absence of sweat glands, dryness of mouth, and this condition is known as ectodermal dysplasia. Why? Because the structures which are made by ectoderm are missing. There are some other disturbances also known as congenitally missing teeth, malformed supernumerary teeth, fusion or gemination. Fusion is the teeth with separate pulp chambers joined at the dentine, whereas gemination is the teeth with a common pulp chamber. Disturbances of dental development, interferences with eruption, supernumerary teeth, or the sclerotic bone, heavy fibrous gingiva, these are all causes of malocclusion, right? Ectopic eruptions most likely occur in upper first molars, teeth. Traumatic displacement of the teeth could be a result of malocclusion as well. Damage to permanent tooth buds from an injury to primary teeth. Drift of permanent teeth after premature loss of primary teeth. Direct injury to permanent teeth. Now, the other heading is genetic influences, inherited in two major ways: disproportion between the size of the teeth. No, it is also important, but I already explained. The slide had the enodontia, oligodontia, and hypodontia. Okay, inherited in two ways, either the teeth or the jaw. Sometimes the jaw size is bigger and teeth are normal in size. Sometimes the jaw size is smaller and teeth are bigger in size. Habsburg jaw is also an example of hypoacromegaly, right? The prognathic mandible of this European royal family is the best known example, and it is considered as a genetic influence. Habit like thumb sucking and tongue thrusting are considered as environmental causes of malocclusion, right? So if a thumb is pressing, if a kid is pressing the thumb against the teeth, and this pressure is maintained for more than 6 hours per day, might result in proclination of the teeth, increase in overjet, narrow arches, crossbite, right? The transeptal fibers was stretched elastically during orthodontic treatment and tends to pull the teeth back towards the original position. Adenoid faces are the examples of respiratory habits, respiratory patterns. If the patient is habitual for mouth breathing, keeps his or her mouth open during sleep, might result in dental anomalies or skeletal anomalies, resulting in long face, narrow arch, open bite, cross bite, which we call adenoid faces, because they have problems in their respiratory pathways, nasal pathways. That's why patient is habitual to mouth breathing, resulting in malocclusion. This is how the thumb sucking affects. During primary dentition, there is no influence. If the patient leaves the habit before the age of 8 years, that will be okay. Otherwise, if the habit persists beyond this time, the permanent teeth begins to erupt, results in flared and spaced maxillary incisors, lingually positioned lower incisors. Why? Because usually the patient is sucking their thumb in such a way that they are pressing the upper teeth forwards, resulting in spaced and maxillary flared incisors, whereas two or three fingers are pointing towards the mandible, resulting in lingually positioned lower incisors. This results in anterior open bite and a narrow upper arch. Anterior open bite is associated with thumb sucking, arises by a combination of interferences with normal eruption of incisors and excessive eruption of posterior teeth, right? So when a thumb or finger is placed between the anterior teeth, the mandible must be positioned downwards to accommodate it. The interposed thumb directly impedes incisor eruption, so the incisors are under erupted and resulting in open bite. At the same time, the separation of the jaws alters the vertical equilibrium on the posterior teeth. As a result, there is a more eruption of posterior teeth, which results in anterior open bite. Tongue thrusting. Do you have any idea, Ali, that tongue thrusting is a cause of open bite or is an effect of open bite? Any idea, Ali? Last topic, tongue thrusting. Is it a result of open bite or it is a cause of open bite? Actually, it was previously considered as a cause of open bite, but now it is considered as a result of open bite, effect of open bite. When there is an open bite, the tongue has to come forward to make a seal so that patient can swallow. Do you understand? If there is an open bite due to some reason, the tongue has to come forward because when we try to swallow, we have to make an anterior seal. In a normal individual, when there is no open bite, the teeth comes together and patient is able to swallow, or any individual is able to swallow, right? But if there is a space between upper and lower teeth, there is no seal, tongue has to come forward in a way of tongue thrusting, and it results in normal swallowing. That's why patient develops a habit of tongue thrusting. But it is totally not a cause, it might be an effect. How sometimes that patient has macroglossia, large size of tongue can have more pressure, it disturbs the equilibrium, it can result in open bite. And the second thing is the habit of patient of keeping the tongue anteriorly to the normal. Means what happens is normally we keep our tongue away from anterior teeth during the start of swallow. But if a patient has a habit of keeping the tongue towards the anterior teeth or touching the anterior teeth palate of the upper teeth at the start of swallow, it might result in open bite. So it could be a cause, but in rare cases. Ideally, it is infect. So the summary is the etiological agents are usually no longer present when growth is completed. Whatever the malocclusion, it is nearly always stable after growth has been completed. So if the habit is removed before the completion of the growth, it is auto-reversible. It reverses spontaneously without any treatment. Sometimes it does not need any treatment if the habit or any cause, that is etiology of malocclusion, is removed before the development is completed. If an orthodontic problem is corrected in adult life, a surprising amount of change is also stable, right? Thank you very much, Ali. I hope you understood well. If you have any questions, you can ask anytime. But please convey my message to all of your group mates that it is very depressing and disappointing that you keep a lecture and you don't come. You must have said, they must have said that they don't want lecture. We don't have any issue, right? But if they have kept a lecture, they have given me time, so they should be there ideally. Otherwise, it is a waste of time, right? No, it's okay. You don't have to be sorry because you are here only. So thank you very much and see you on Tuesday, inshallah. Take care.